Okay, cool. So, hello everybody. I'm John. I'm the communications director here at TheraPsil, and today I have the absolute pleasure of chatting with Dr. Valorie Masuda. Val is a board member at TheraPsil and is a real pioneer in the treatment and application of psilocybin to support palliative care patients. So, thank you, Val, for making the time to chat with me. I was just telling Val that we've never met before, and we've never met in person, never chatted on any surface. So this is exciting for me as well. Um,
Yeah, in the COVID environment.
yeah. Um, but Val's a board member at TheraPsil, as I said, and a doctor on Vancouver Island. And I think, Val, you probably helped the most patients through 56 in the SAP process, if I'm not mistaken. So I'd like to know how you got involved with TheraPsil. I know you're a palliative care physician. Like, I
Yeah.
guess what led you to that, and yeah, maybe we can start there.
Oh, I'll just start from the beginning and just keep going then.
That's cool. That works.
Yeah, so I've been working as a palliative care physician for the last uh, close to 10 years. And as a palliative care physician, my job is actually to manage symptoms for people with terminal illness, as well as to understand their goals, what their life priorities are, how they want to move forward with terminal illness, and then to really align medical care with those goals as well. So one of our real challenges is treating people with what we call existential distress. And this is people who, you know, have a terminal illness diagnosis and they just can't get out of the fact or even have any other thoughts aside from they're going to die from this cancer, that it's unfair, that it's robbing them of who they are. Their life no longer has any meaning or purpose, that they are going to be just a burden on their family. And this really is profound, profound suffering. And family are often helpless in providing any comfort. The patients often become very isolated. They isolate themselves from their friends and their family. And it can also have real impact on other symptoms. They can feel more shortness of breath because there's underlying anxiety. They can have really difficult to treat pain. And previous to um, really today, say about 5 years ago, or really actually it was about 10 years ago, when people have this existential distress, quite often they are really unable to cope at all and have asked for what we call terminal sedation, which means, doc, just put me to sleep. I don't want to wake up. And we used to actually do that to people who were approaching the end of life, but we could only do that for people in the last few weeks of life. So individuals had to suffer for months and months and months before this ability to just eliminate distress. And then in 2016, medical assistance in dying came on the scene, and people could access medical assistance in dying for this kind of suffering. Um, so people say, well, cancer patients, terminal diagnosis, I'd be suffering too with this. But, not all patients have this level of distress, this mental anguish. Um, I would say maybe 5-10% of people with a terminal diagnosis. And even within that 5 or 10%, there are some people with just such extreme symptoms. So back a couple of years ago, I was involved with a patient who had this kind of extreme existential distress, and it was impacting on her pain. She was very young, um, and she could not get out of this idea she was dying. She didn't want to talk about dying. She didn't want to. The whole thing was super unfair to her. She'd been ripped off of an early life, of marriage, of children, and she spent her entire time sobbing in a darkened room. She had really difficult to manage pain, and despite several uh, trips to a tertiary care palliative center, um, plus a number of procedures, we could not manage her pain. And even the specialists, the pain specialists say, we can't get through to her. She has so much whole person pain, which is wrapped up in this existential distress. So coincidentally, I happened to run into Bruce Tobin and Spencer, excuse me, Hawks Hill at TheraPsil. And I had read some stuff about the use of psychedelics in people with this kind of distress, but it was really sort of in the research literature, and I didn't realize that this potentially could be a tool we could use for my patient. And I said, Bruce, I have this patient I can do nothing with. I can't do anything with her pain. And he said, okay, let me meet with this patient. And he did so. And he said, Val, like, we need to get her MP on board. We need to put in application. And we put in application to Health Canada for a compassion exemption. And we got, and it was Minister Patty Hadju at the time, and she granted the exemption within 24 hours. And we were able to treat her within 48 hours of the exemption. And for me, that patient had a transformative experience. Within 24 hours, we could manage her pain with half or actually up to a third of what the pain medications she was requiring before, but we could manage her pain. She could talk about death and dying. She reconnected with her friends and family before she died. And for me, I said, okay, this is a game changer for me. So over the course of the next year, yeah, she was the second person actually in Canada to receive a Section 56 exemption. So over the course of the year, I had treated maybe 4 or 5 patients under the Section 56 exemption, but I'm not a therapist. I had to kind of resource therapists in the underground community. I just didn't find that very satisfactory. And so I reached out to a nonprofit group who is actually a group, a program group under VIU and Island Health called Roots to Thrive. And this group was offering a psychedelic assisted therapy program within a group therapy program called a community of practice, where people come together, patients come together, and they learn to, one, get out of their head and into their body, which is just so important to get out of this narrative that life has no meaning, that you're not good enough anymore, that you're going to die, and it's such a ripoff, and God has deserted me. And that narrative, you get out of the narrative, you learn tools and techniques to get into your body. You spend time in a group of people who are just like you. And it provides a community where patients' feedback is like, nobody got this. My friends don't get it. My family doesn't get it. But these people get it because we're all together in the same group. We all have terminal illness. So I thought this is a phenomenal opportunity. So we brought 10 patients under Section 56 exemptions through a community practice program. It was a 6-week program at the time, and really found that it was extremely beneficial. It was like the community of practice with the psilocybin treatment really catalyzed a durable treatment response. And we we had really success. And then this year, Health Canada said, no, you can't, no more Section 56 exemptions. You'll have to go under the Special Access Program. So we brought a second cohort of patients under the Special Access Program. It was a group of 8 patients. 2 unfortunately died prior to entering the program or completion, really entering the program. We had one patient die in the early weeks of the program. It was an 8-week program. And the people that went through had a phenomenal experience. With this group, we also treat the patients in a group. So they have their psilocybin administered by a physician in the group with a multidisciplinary team that supports them. And then the integration is also done in group with a multidisciplinary team. So it's a very robust and safe system. So we had great success with our second cohort. And then our third cohort, we wanted to bring in, Health Canada said, no more. You cannot have more special access approval. You're running a program. This is not what our special access emergency access to treatment is designed for. You must run a clinical trial. So we said, oh, well, we have, 10 people that want treatment. A couple people Again, we lost a few in the wait time. Um, so we ended up with 8 people who wanted treatment, and these people have terminal illness. They can't afford to wait indefinitely. So we actually put together a clinical trial and received real support from Health Canada Clinical Trials. Um, Now we're going forward with no funding, and our whole team is working volunteer to put this clinical trial forward. Um, and we did actually, we negotiated with Health Canada, said we have these people waiting. We can't wait for all this approval. So they actually allowed us these 8 more applications through the special access program for psilocybin. Um, excuse me. And we managed to treat a third cohort of patients, but we now cannot access any more psilocybin through the special access program, and our program has to resort to a clinical trial. So we did manage to get what we call a letter of a no objection letter from Health Canada for a clinical trial. We are in the process of battling um, the ethics review board because nobody actually wants to be our what we call our board of record. So we're being tossed around, um, trying to find somebody to support us. And we have no funding. So we are going to be relying completely on private donors to support these patients because these patients cannot afford um, the costs of having psychedelic treatments. They haven't been working. They often are worried about how they're going to support their dependents once they're dying, once they've died. And so, we have been offering this program free of charge for our participants and only asking for a donation or whatever they can afford to pay going forward. So, when we look at accessing these patients who are suffering, their ability to access this program we know that works, medicine we know that is safe and working. We cannot right now because we're paralyzed by this bureaucracy of trying to get one funding and this therapeutic trial up and running.
So, wow. Um, I got a lot of questions. I guess to start, I'm wondering, Val, why do you think there is pushback from Health Canada with this? I mean, as we're seeing, like to me, I live in Toronto here, and we just got a store was just opened on Queen West called Shroomies, where you can walk right in and purchase psilocybin mushrooms. And I went to check it out because for work,
Mhm.
and there was a line out the door. There were like 50 people there. It's been open for 6 weeks, and they've got like 800 five-star reviews on Google. Everybody knows that this store is there. And in Vancouver, I was there recently, and of course, for work, I checked out the stores, and like same thing, they were packed. So, given that this is essentially decriminalized, and to me, it seems like a clear logical extension of like this all happened with cannabis years ago.
Mhm.
Why why is Health Canada so reluctant to support patients this way? I mean, with cannabis, if I'm not mistaken, there was no clinical evidence when it was federally legalized.
There was, and the whole access to cannabis for medical use really was about legislation change. Like, let's face it. Um, Now, there was a lot of talk about let's get clinical trials, let's prove that this works, yada yada, and clinical trials are going to take years and years, and the public said, no, we have a right to access medicine that works, and that's where the legislation changed. And really, if the government wants to do this properly, they have to recognize that one, the underground is going to flourish. And this is not what you want to actually support. By making, um, you know, I guess, access to GMP API product, to making it absolutely impossible, really essentially impossible. And for us, SAP has been shut down. We are providing this service to people who are suffering with terminal illness, and we are being denied access unless it's through a clinical trial. And we have to try to do this as on a volunteer effort, right? And to try to get private donors. And so you can see the number of hoops we have to go through to offer patients alleviation of their suffering is believable. And, I understand where Health Canada is coming from. One, the SAP program and Health Canada are not designed to actually um, approve biologics, right? They're not going to approve psilocybe cubensis. They're just not. They said that's not what they do. So yeah, they can do drugs, they can do extracts where you could prove how much psilocybin is in there, but they're not in the business of approving, magic mushrooms. So that 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 avenue is closed. So you know, unless the government changes the legislation, which I think President Biden is considering, his government is considering changing their legislation so that you're deschedulizing it so that this is a medicine that is offered to healthcare practitioners for the treatment of patients for indications. Unless we see that change in the scheduling of psilocybin where it comes off restricted into controlled, we will never be able to access safe product for physicians, therapists, psychiatrists, for people dealing with patients that are suffering from accessing illegal drugs, opioids in this mental health crisis to survive. These are survival techniques that people are turning to in this mental health crisis, and and to deny them access to something that is safe is in my mind just it's not serving the Canadian population at all. So I can only see access changing by legislation.
Right, and actually, I think it was well, I think it was a lawyer, someone on the legal team, said that he thinks that they folks in Health Canada are actually secretly thrilled that we're bringing forward this charter challenge because it means that they won't have to bring it forward themselves. That, like
Absolutely.
with cannabis, concerned citizens, people that are suffering, they're the ones that are bringing it to them. Like, oh, rats, we got to do it now.
Exactly. I mean, if you look at what Health Canada's mandate is, they're supposed to be protecting the Canadian public, and they're supposed to be looking at food and drugs. So psilocybe cubensis is not a food. It contains a psychoactive substance in it, which they say is a drug, but it's not a drug, right? So it's just like cannabis, right? It's the same classification, and unlike cannabis where you kind of grow, this stuff you could go in the forest and find. I mean, to outlaw a a species is is utterly ridiculous. And really, Health Canada, this is outside of Health Canada's mandate. So they're trying to fit in, psilocybin containing plants or fungi. They're trying to put it in, round peg in a square hole. There's nothing that the exemption process really it doesn't work for it. SAP doesn't work. I mean, SAP, the Special Access Program, is designed for patients and physicians, primarily physicians, to access drugs that are not available in Canada, but they feel could be life-saving for a patient that they have. So the physician applies for access to this novel drug, which is not available in Canada, so that, and they also apply for, importation usually, or access from a manufacturer to then deliver this drug to the patient. So this is not the program it comes under either. But each time exemptions, the first 100 exemptions, okay, but when they look at 1,000, like the health minister's like, time out, this is not working. Then SAP gets involved, and after the first 5 months, it's great, and then boom, they get 1,000 SAP requests, and they say, we can't even deal with this, like we have actual real drugs that we need to authorize for real physicians for their real patients that are usually chemotherapy drugs or novel drugs for the treatment of other kinds of life-threatening diseases. It is not the avenue. So, you know, now they're throwing it to Health Canada Office of Clinical Trials, And the Office of Clinical Trials is really happy to get applications for clinical trials because we want clinical trials. We want scientific evidence that we can show that this stuff works and it's safe. And the Office of Clinical Trials, Health Canada doesn't believe we have all the evidence yet. So they are trying to push people through the clinical trial route. But this isn't big pharma. We don't have the big pharma dollars for research and development and clinical trials. And so who's funding this? It's Big Mushroom, right? The new upcoming grow ops that are trying to produce psilocybin mushrooms and extracts and all this other stuff. It is also the big mushroom companies that are trying to look at clinical trials looking at microdosing because let's face it, microdosing is going to be the big ticket item for them. They're not interested in clinical trials looking at one time 25 milligram doses of psilocybin. So, for those that really need this treatment, we're not going to see it outside of a clinical trial going forward in the next few months. So, where does that leave the Canadian population of terminally ill patients who are suffering, patients with treatment resistant mental illness? How are we going to deal with these? We're just relying on these poor patients to continue their survival techniques of resorting to substances for survival. And here we are, still in the opioid crisis and the mental health crisis.
Right. I mean, I believe Paul Lewin, I'll mention him again, he's the lead counsel on the Charter Challenge. He was really quite upset in chatting about this, talking, basically saying that clinical trials are unethical to force patients down that, or at least ask them or direct them down that path because it's not treatment. That this is a scientific objective that you're putting them into. And I mean, you mentioned the underground thing. In my position here, I get so many emails from people that say, hey, my mom is dying, my brother is dying, and I think this could really help them. And from their little description, I know that they won't get legal access. It just won't happen.
Yeah,
And so
it's
when I
not going
tell
to
them
happen.
that, they say, oh, well, actually, okay, that's good because I know a guy here in my town who might be able to facilitate it. And of
Yeah.
course, like there's lots of fantastic underground therapists, but is this really
Mm-hmm.
what the federal government and Health Canada want patients to be doing? It
I
seems
know,
clear
and
that they
it's
wouldn't.
more about, well, if we look at a harm reduction model, because we know that patients going in the underground, they're vulnerable. They're vulnerable financially. They're vulnerable, physically vulnerable under the medicine, spiritually vulnerable, emotionally vulnerable, sexually vulnerable. And we've heard of case after case after case where patients have been abused, sexually abused under the medicine. And so we need to, I'm not saying there are not really excellent therapists in the underground because there are, but there's no system of professional accountability. And
Right.
so we need some sort of professional accountability to keep patients safe. And forcing patients into the underground is not safe. It is not about harm reduction. It's just so unsafe. So, if the government wants to say, okay, let's do a model of harm reduction, let's just say, like, give everybody like in January in BC, where psilocybin is now um, is also decriminalized. So we have MDMA decriminalized. Why don't we decriminalize psilocybin so that people can actually seek out you know physicians, therapists who are trained and who can then deliver good set and setting to these patients. Um, let's look at a harm reduction model just saying, look, we know there aren't like phase 3 clinical trials out there, but we know that the general population is accessing psilocybin in really unsafe set and setting. So let's just do what the United States is planning on doing, is just saying we're going to move it to a different schedule. We will allow healthcare practitioners and therapists who are trained to provide psychedelic assisted therapy to access this medicine. That's not that far out, you know?
I mean, you mentioned the decrim in BC. To me, when that was announced, I mean, it was great to hear that you won't go to jail if you have a certain amount of these substances. But the fact that psilocybin and LSD and mescaline, that these traditional psychedelics were left off that decriminalization list, I was like, is that not a clear indication from the government that these are not harmful substances? And that's why they've not been included on this list?
But they're still illegal. So as a
Right,
healthcare practitioner who is trained to administer psilocybin, to support patients in psilocybin and the integration. So I'm not supported, right, to provide that service to my patients who are obviously suffering and they need that support. So, I don't, I don't know where to go. Right now, I am just, trying to pedal as fast as I can, getting this clinical trial approved so I can treat some patients over the next year or two and offer them this service.
right.
And it's a
No, I
service.
mean,
So I'm doing service delivery under the guise of a clinical trial. So, how are we going to provide the service?
right. And I guess talking about these other substances that have been decriminalized,
Mm-hmm.
I remember one thing. I saw you speak at a TheraPsil event, Val, and you talked about ketamine, and you were a healthcare practitioner who was approved to
Mm-hmm.
use psilocybin as part of your training, and you've also done the therapeutic dose of ketamine. And I remember you talking about, someone asked like, why are they not allowing psilocybin and they're allowing ketamine? And you said that ketamine gets you here and that psilocybin gets you here in
So
terms of.
it's like ketamine has been in use medically for decades and decades. So as an emergency physician, I that was my previous life for 20 years. I used a lot of ketamine as an anesthetic, right? And
Right.
globally, ketamine is available as dissociative anesthetic, and it's very unique compound in that at these kind of doses, people also can have kind of a psychedelic experience, but it is limited to a short period of time, so it can reduce the activity of the default mode network, um, but not the same as classical psychedelics. And and the the I would say the duration of neuroplasticity with ketamine is probably a lot less than with some
Mm-hmm.
of these other classic psychedelics. They work quite differently, and when we look at the John Hopkins clinical trials in 2016, we're looking at people that had one dose of psilocybin and a durability of effect that lasted over 6 months. So when people are treated with ketamine, we see ketamine clinics popping up all over Canada, all over the states. People don't have one dose of ketamine and they walk out, with substantial decreases in their symptoms. We see people having to go back over and over again. Some people are getting ketamine treatments every week. There's no integration, there's no therapy. It's come in, get your hit, and go. Now, that isn't therapy. That's not responsible. So, psychedelic clinics are popping up. People are paying big money to take their chances in this kind of space with ketamine. So, I mean, with psilocybin, if we can legalize it in the proper framework with the proper practitioners who have professional training, and they are professionally accountable to their college for provision of good professional care, this is what's safe. And so the government, this is the only way that's safe. So the government has to change the legislation.
Right. Yeah, I guess I it's just odd to me as an observer that these, like, there's a ketamine clinic at the top of my street. I pass by it all the time, and I've heard also that ketamine can be addictive to patients, and
Mhm.
I guess I'm just confused as to why Health Canada is perfectly comfortable with one class of drugs here and one that doesn't support patients in the same way. And
Yeah, and it all has to do with ketamine is a drug. It has a drug identification number. It has been used. Its safety is very well documented. There are many uses of ketamine. some off labels, some on labels. As a palliative care physician, I use ketamine as in the treatment of pain. Um, sorry, at doses that are not psychedelic doses. Um, so it's out there. So people are just using it for a different indication. Um, Psilocybin or Psilocybe cubensis or other mushrooms, psilocybe mushrooms that are being accessed for psilocybin, this is outside the realm of Health Canada. This is totally in the jurisdiction of legislation, the same as cannabis. And so this is the problem. If this was a novel drug that came out and it was tested, Health Canada would have no problems, right? Couple years of clinical trials, phase 1, phase 2, phase 3, done, it's on the market. Usually at a very high price tag. This medicine, this plant medicine or a fungi medicine, um, it they don't know what to do with it, right? Um, there's there's sure there are clinical trials that are available, but it's just a big mess. It's a big mess. So um, I think the exemptions office and the clinical trials office, or not the clinical trials office, the SAP office would be very happy if there's a change in legislation. I mean, there are ways of post-marketing surveillance or whatever, or surveillance of patients that are undergoing treatment with proper healthcare, registered healthcare providers. I mean, there's ways of being able to monitor outcomes, patient outcomes. So, I think we need to have to go through that route for sure.
Right. Yeah, I mean, at this point, there are patients that we support at TheraPsil that I'm thinking of one in particular, and we chatted recently, and she said something like, "I'm not getting the help that I need, and I know where to get mushrooms, so I'm just gonna do it. And come and arrest me if you feel like it, but I don't think you will come and arrest me."
Like, no. And so people are just having bad experiences in a very vulnerable space, taking whatever they can, and we don't know what they're accessing as far as product goes, or is that product contaminated, or how much psilocybin is in that product. So people are just going out and taking it and lying down in their bedroom, and Health Canada has got to see that this is not okay. The Minister of Health has got to say we have to protect Canadians from that kind of experience, because that's the only thing that they can experience right now. Forcing people, like you said, to undergo a clinical trial in order to access something they believe is the only thing that can alleviate their suffering is not ethical.
Truer words have never been spoken. Yeah, it's it's very strange to be to still be talking about this for some reason. It feels like there's no one listening over at Health Canada. Although I'm always reminded that there are good people that work there and they want to support patients, and
There
that,
are.
as I mentioned, that they a lot of them would be like, thank goodness that this legal challenge is coming
Yeah.
forward, so that we don't get inundated with these applications that we know we won't be able to approve.
Yes,
Um,
and I think, and I have to say the people at Health Canada are good people, and they are following their mandate. This
right.
has to come from a totally different way of seeing. Um, I yeah, even if it was just a pure harm reduction model, like decriminalizing and then allowing practitioners to, basically when a medication is decriminalized, then people feel okay with going and getting it tested, right? So, you get your substances tested. Um, and I think this is really the whole idea of decriminalizing heroin and the opioids and MDMA, as the decriminalizing these substances is really going to help, because then we're going to see a drug testing pop up all over the place, and people not feeling like they're going to be arrested if they walk into a drug testing area to make sure that they don't have a tainted drug supply. Um, and I think it's great. It's going to allow people to hopefully access treatment, who felt that they couldn't access treatment um, because they would be criminalized if they access treatment. So I think this is a very good thing. But what we're talking about is yeah, we could just decriminalize psilocybin, but we really need to legislate it as a proper therapy in the proper hands of proper therapists. And that has to happen in the states. It's going to happen, and so Canada has to follow suit, because you know what's going to happen as soon as it's legalized in the states. They're going to have an extraordinary amount of the psychedelic tourism hit the states, and
Right. I mean, we're
for
already seeing that
Canadians.
for
Oh
our
yeah.
patients. Sorry. Yeah, like they're like, hey, can I just go to Jamaica? Like, yeah.
Oh yeah, go to Jamaica, you know what, ayahuasca, go to South America, but you know, these are Canadians who have general suffering. Um, and to deny Canadians access to treatment, and remember in 2023, if somebody has treatment resistant depression, they can ask for actual euthanasia. So we would rather provide euthanasia to a patient suffering from mental illness than access to a psychedelic. And I think that is absolutely horrendous.
Yeah,
Um,
that's a big focus of our when we go to Ottawa at the end of the month, is to say, yeah, when this legislation comes through and the amendments to the MAiD program are enacted, that will be a hugely problematic thing for us to accept, that you're willing to provide medical assistance in dying to people before you grant them access to a mushroom, which I know that we call it. It's not plant medicine, but it's along the same vein there.
or even
That's
other psychedelics like MDMA. Uh, because psilocybin may not be the therapeutic psychedelic of choice. It may be LSD, it may be MDMA, it may be something else. But when I look at patients surviving with mental illness, often they are really struggling with the social determinants of health. Most of them are unemployed. Most of them are living um, on welfare. Some of them are homeless. Many of them are resorting to using substances for survival. Um, Many of them are dying because they're trying to access substances for survival when we look at the tainted drug supply. Um, and so when we say, and these people are often, because of their mental illness, socially isolated. And so we say all those social determinants of health, a patient comes in over and over, they're unable to get better with our traditional treatments for mental health. And then you have two psychiatrists that say, yeah, they've tried everything. And then we can actually give them a lethal injection. If you offered those patients back, you know, support. Like if you talk to somebody, you say, have you accessed like therapy? Well, it's a 2-year waiting list to get a psychiatrist in my area. And people are not, and therapists, these are private pay. So to access a therapist, $150, $200 an hour, these people can't afford. So when you can tell me that every patient that applies for medical assistance of dying has all their social determinants of health, that have been offered regular therapy sessions and have been offered a psychedelic with that, so that they have an opportunity for neuroplasticity and to break that pattern of thought, then maybe that's an option. But you hear time and time again of people who thought they were at rock bottom, but something happened, some transformative event happened to them with or without psychedelics, and they changed, and they no longer wanted to have medical assistance in dying, or they no longer wanted to commit suicide, and they then transformed to have productive lives. And I just think it's one thing to treat somebody with terminal illness with MAiD because you know they're dying. It's another thing to take a 30-year-old that has their whole life ahead of them and euthanize them because they are unable to access the help that they need.
right. Yeah, I've certainly had conversations with patients supported by TheraPsil, and they say they haven't heard back from Health Canada, and then when they do, that they're pointed out that they could choose MAiD if they so wanted to. And one patient in particular I remember was just like furious to hear that. Like, and she's still around. She she got her psilocybin and she did her therapy, and it renewed her. It was a life affirming medicine and just renewed her
Yeah.
sense of life, and she was like, I'm so glad that I didn't choose MAiD, which would have been
Well, we
legally
have
available to
patients
me.
that have applied for MAiD, our terminal illness patients that have come through the program, and one actually had a MAiD date set and canceled her MAiD date because she now felt that life was worth living.
Wow.
Um, we had another person who said, well, if this, I'm getting MAiD. And then he said after his psilocybin journey, he's like, nope, that's off the table. And
Wow.
so, these are people that are dying that have said, nope, no to MAiD. I'm talking about people who are living. If we give, even if it's and, really our studies that are out there show 80% effectiveness. So when we say, even if half the people responded, we would be saving half the people from death with mental illness that have applied for medical assistance in dying. So
Right.
it just, to me, it's just a no-brainer. I'm a MAiD assessor, and I know of MAiD providers that say in 2023 they're actually relinquishing um, their not their well, they're basically stepping back as MAiD providers because they do not want to provide MAiD or be coerced to provide MAiD for people with mental illness. They are that um, against this new legislation.
Wow. Yeah, we're actually reading Dr. Stephanie Green's book. This is Assisted Dying for our work book club right now,
Hmm.
and I have I must confess I was not the most up to date on medical assistance in dying and what it really means here in Canada, and I've been very moved by some of the stories of people that have opted for MAiD,
Mm-hmm.
um, and it's very clear that it's the right option for some people.
I mean, for medical assistance in dying, for some people, accessing it aligns with their core values. This is the way I want to die. I want to die with control. I want to be able to say goodbye to my family. I don't want them to see me lying in bed for weeks and weeks and weeks, just getting weaker and weaker. And, they're not coming from a place of suffering. They're just really pragmatic about it. They said, this is the way I want to leave the legacy of a good death. And this is the way I think a good dying experience is. And I'm totally fine with supporting that. It's those people who just are so, you know, like if a patient says, I want medical assistance to dying because I'm in too much pain, I'm like, that's not okay. Let's treat your pain. And people will say, oh my God, now that my pain's controlled, I want to live, right? So if somebody can, or shortness of breath, I'm really short of breath. I just feel like, I just would rather die than struggle with breathing every day. Oh, let's treat your shortness of breath. And then they go, oh, well, I'm okay with living now. So if somebody says, I suffer with this extreme depression and anxiety because I have this terminal illness and I'm going to die. I can't talk about death. I My friends and family don't visit me anymore because, you know, I can't I can't engage. You know, I want MAiD. I'm like, you know what? Let's treat that. And so we have the tool to treat it. So for me, I get so frustrated thinking, we have a tool and we are being prevented from using it. And hundreds or thousands of people could access, you know, this treatment and actually have their suffering alleviated. So it's a
Oh,
no-brainer.
I can't even like I think we have over 900 people on our wait list here at TheraPsil, and I know that is just like a tiny fraction
Mm-hmm.
of folks that could be supported by this medicine. Well, uh, wow, I feel like I learned a lot today from you, Val.
Oh, thanks, John.
Yeah, I'm super glad that we got the chance to chat. I don't want to take up any more of your time here. Um, we didn't really get into your viola playing or your sustainable farming, but maybe we can take that offline sometime
Sure,
and chat
anytime.
about it there. And yeah, thank you again for this. This is I am so excited to show this off to folks in our community
Mm-hmm.
and to get this online because it's such an important conversation, especially that last thing we talked about there
Mm-hmm.
with medical assistance in dying in Canada and psilocybin access. So thank you again, and
Okay.
yeah,
Thanks,
what
John.
a pleasure.
Okay,
Okay,
we'll see you
cheers.
again, I'm sure.
I certainly hope so. All right, bye bye.